that oftentimes will be the main reason that drug doesn't make it to market. In kids and adults who have underlying liver disease, where the numbers may go up and down as part of their natural history, there are people who are looking at this, but it's really hard to design a drug trial where you don't have all these adverse events of liver numbers going up that causes it to kind of get halted early in its course. And so I think that's kind of a constant challenge in liver disease, is trying to design a trial where liver number elevation doesn't necessarily mean it's a drug effect, but being able to definitively determine that is difficult. And so I think there's still hope for 4-phenylbutyrate. As far as I know, there's no active trial that's ongoing to look at that, but I think there is active ways that people are trying to study these defects in various laboratory settings, cell cultures, animal models, and the like, where hopefully you can kind of give drugs and do kind of drug studies to understand how these types of livers may metabolize a drug to see if it's beneficial.
Great, thanks for that. Okay, we can transition over. We can turn you off, Dr. Squires, and we'll open up for Dr. Soltys, and then if we have time at the end, we can all open up for another discussion if we have the time for it. And if not, we can always do follow-up questions. I know that these guys love it when I email them with questions, and they're happy to answer. So we'll get everyone's questions answered. But Dr. Soltys, I'll let you take it away.
Thank you. Did Jim entertain you all?
Very much so.
I'm so sorry.
No, it's fine. You got to do what you need to do.
Yeah, always a little unpredictable. So let me get my screen up.
Sure.
And how's that?
That's great.
Okay, great. And so part two of kind of yesterday's talk, I kept promising to talk about the different issues that you can see with liver transplant for PFIC, and I really I honed it down to kind of the two major types of PFIC, or two major phenotypes. And so so when you talk about the complications after, you have to kind of think about what the disease is going in. And so PFIC 1, or Byler's disease, and is really the kind of penultimate, or kind of the first disease discovered for this. It has very severe cholestasis. It's a systemic disease, and it's important to understand that it's a systemic disease in the way that your body handles bile acids, in the way that your body handles a lot of different substrates. And although pre-transplant, it's manifested by cholestasis, you often can also get pancreatitis associated with it. Patients with PFIC 1 also have chronic diarrhea before anything, before transplant, before diversion, and so it is an underlying issue. There's also an underlying issue with nutrition, and most children with PFIC are on the lower end of the growth curve. Actually, in reality, the majority of patients that we see for transplant have failed medical management, have failed conservative management, and are generally relatively severely malnourished. And it's important to kind of realize that a liver transplant is not a small surgery. I don't have to tell you that. We talked about it yesterday. And that you do require a lot of nutrition kind of going in. And so when you look at liver transplant, most of the patients, or a fair number of the patients who are now being transplanted for PFIC1 have had a biliary diversion. And so from a pre-transplant standpoint, the things that lead you to transplant after diversion is chronic liver disease, fibrosis, and the development of portal hypertension. And so children that have a stoma, or have a piece of intestine that's coming out of their abdominal wall, will, with the development of portal hypertension, often develop fluid inside their belly. That's called ascites. And they oftentimes will, at that point, develop peristomal hernias. And so again, stomas, the piece of intestine that you see coming up through the abdominal wall, kind of go through a hole, but there's only, there's small stitches kind of holding them up to the abdominal wall. And the spaces, there's always a space when you make a hole to put the bowel through. Those spaces can get distended. Those spaces can get weak, and you end up with an area of a hernia between the bowel wall and the abdominal wall. And so you can end up with a really relatively nuisance peristomal hernia, especially if you have ascites inside the belly, which can leak out. At the same time, the blood vessels that drain this jejunal interposition are connected to the portal vein. And the portal vein goes into the liver and it drains all of these. And so when you have portal hypertension, you can develop varices at any site where the intestine is exposed. And so the common sites that you see this after diversion for portal hypertensive bleeding is at the stoma itself. Those are a bit of a nuisance, but at least you can see them and you can control them with a stitch. Varices that are inside this portion of intestine that goes to the bile duct, you can get to with a scope if you needed to. And again, the jejunal piece of bowel is not very long. And then the more the more troubling sites are areas like this, where two pieces of intestine are sewn together. You can develop varices at that site. And that is hard to get to with a scope. Those are areas that can cause significant bleeding. And similar, if you have a gastrocolonic or a colonic to gallbladder anastomosis, it can bleed from there as well. When you're thinking about transplant, you also have to think about the biliary diversion and the anatomy that you're starting the transplant with. And so you can actually use this portion of intestine at the time of transplant if it's long enough. There's no reason to waste bowel. You can use that to hook up the bile duct with the roux limb, which we've seen before, and I'll show it to you in a little bit. The other thing on kind of the medical side of this, by kind of nature of their disease, children with FIC1 are nutritionally behind. And they often have a dramatic decompensation in that. They often get much sicker and much punier, to use a typical pediatrician word. It's that children become very puny. They become they have fat malabsorption, they have ascites, they have muscle wasting, they become very frail. And that is much more common in patients with PFIC-related end-stage, PFIC1 related end-stage liver disease. And so oftentimes children require supplemental feeds, whether it's by nasogastric tube or G-tube or hyperalimentation, where you give them food by vein. Because the children have issues with fat malabsorption, you oftentimes need to supplement their hyperalimentation with lipids by vein as well. And so it's important to kind of, when you're starting to think about transplant, when you're starting to think about, am I going to go ahead with transplant, you need to make sure that the child is in the best shape possible. And oftentimes in kids with FIC1, that requires some time on parenteral nutrition. When you think about the post-transplant factors, things that are going to be an issue after transplant, diarrhea is a common issue after liver transplant. It actually oftentimes gets worse after liver transplant initially. And the treatment oftentimes is the same as before. And so you give bile salt binders, you do things like cholestyramine. You can actually slow down the colonic motility with utilization of medications. And so you can actually help that. But it's important to understand that the liver transplant itself doesn't fix any of these other systemic diseases. And so the new liver is making normal bile salts. The enterohepatic circulation, the circulation of bile salts, is actually working better than it ever has in the child's body. And there's all of these bile salts that are ending up in the bowel, and that causes some choleratic diarrhea. It also, early on after transplant, is much more of a problem. And so the children have electrolyte imbalances. The medications that we use to prevent rejection, a lot of times cause issues with kidney short term. And so children oftentimes have some degree of kidney insufficiency early after transplant that you really have to be careful about. And so maybe a child after a biliary diversion who's not on tacrolimus, who's otherwise well, if they get a little bit dehydrated or if they get a little bit acidotic, you say, okay, well, I can manage them with some oral bicarb and increase the amount of fluid that comes into the patient, by mouth. You can't really do that early on after transplant because of the other medications they're on. And so oftentimes children with Byler's would need to be readmitted to the hospital or seen in an outpatient area that you could give intravenous fluid and then have labs checked the next day. And so it's a little bit more of an issue. And again, it's not permanent. It's something that would be, I don't want to say nuisance, but it is something that is just, it's almost expected in children with FIC1. It's something that you really have to watch out for. And unfortunately, there's not a lot of medical treatment, but again, it seems to get better. The other complicating factor when kids are on immunosuppression, the immunosuppressive medications have to be absorbed, and they're absorbed all through the bowel. Kids that have severe diarrhea oftentimes have issues with fluctuation in the medication levels. And so it's another reason why sometimes you have a hard time early after transplant adjusting those medications in the face of the diarrhea. And again, the management is really similar to pre. You can do bile salt binders, you can do anti-motility agents, and you just have to be very careful about replacing electrolytes. Again, 3 to 6 months after transplant, this tends to be much better tolerated. And we'll talk a little bit about this in a few minutes, but I don't know, nobody really knows the effect of a post-transplant diversion or even, I dare say, an IBAT inhibitor on this process of diarrhea or this issue of diarrhea after transplant. What about weight gain? There's actually a couple of good studies that demonstrate good weight gain in children with PFIC after liver transplant. They come into the transplant very small for age. They have moderate, at least, malnutrition prior to the transplant, but catch-up growth really does occur despite the diarrhea. And oftentimes children, because they come in to the transplant without great nutrition, oftentimes post-transplant, and I would say to this to any family that's kind of going toward transplant for PFIC1, I would expect feeds, tube feeds after transplant in an effort to kind of help, and even a short-term period of TPN or hyperalimentation after the transplant, just to allow to kind of account for the metabolic stress of a transplant. I tell people this all the time that after you have a major surgery, your body, albeit when they put us together very smart. It's not perfect, and so if you've ever had anybody that has had major surgery and you put your hand on their body early after the transplant, their skin is boiling hot, and the reason that is that they've become very catabolic, which means for some reason, and it's a response to stress, I shouldn't say for some reason, it's pretty well understood why. In response to stress, your body breaks down protein, your body goes into a very hypermetabolic state. Anybody that's had major surgery will appreciate, especially if they're old like me, you'll appreciate that you lose weight after surgery. And one of the reasons you lose weight is that your metabolism is 5 times normal, after a major surgery. Unfortunately for kids with PFIC1, it's the same. And the amount of calories that you need after transplant, is 2 to 3 times normal. And to do that with just eating oftentimes is impossible. And so again, I would just, stress the idea that post-transplant hyperalimentation, tube feeds is more expected in children with PFIC1 than other diseases. Fat-soluble vitamin deficiency. So kids with PFIC1 will remain on ADEC, well after transplant. It's well documented. I would expect that as kind of one of the medications that the children would be, mostly because they are so behind to start, regardless of how much you've given. Pancreatitis. Transplant obviously does not change the pancreas, and so the cells inside the pancreas, you still have episodes of pancreatitis. And our longest survivor after a liver transplant for Byler's, we'll talk about that, has actually had episodes of pancreatitis that has been troubling. kids and adults can get very ill from pancreatitis. And again, the episodes are not, it's not a constant problem, but most patients will have an episode of pancreatitis in their lifetime. And it should be well in the differential of any patient that has a liver transplant for FIC1, any patient that has, vague abdominal pain, and automatically should kind of be worked up for pancreatitis and treated accordingly. The most popular and biggest thing that everyone will hear about is post-transplant allograft steatosis. The mechanism of this is unknown. It seems to be related to the enterohepatic circulation, and there's many studies that talk about this, and I'll go into some of them. That why would you do a transplant? And I've actually it's not uncommon for me to talk to other doctors as popular as I am, right? But I do talk to a lot of doctors, and actually I've had physicians from different parts of the country say, well, we didn't think that you'd do liver transplant for FIC1 because they all get really bad liver fibrosis and scarring, and they all get fatty liver after the transplant. And there's studies that suggest that, and why would you do a transplant? And those are the kind of conversations that frustrate me. I think a lot of this came from a study in 2011, and this is a Japanese study using living donors, and so the number of patients is small. The survival that they had in 2011 from living donor, and I think a couple of those were living related, so they were heterozygote donors, which has no bearing on anything, but just as a statement. There was no mortality post-transplant from their underlying PFIC1, and so the patients that died after transplant died because of transplant-related reasons, and the results aren't great, but it doesn't have anything to do with PFIC. And so when you look at their overall patient population, they did biopsies after transplant, which was great, but they started to say that patients had post liver transplant PFIC cirrhosis in about 60% of the patients. And when you look at that, and you look at the numbers, and they talk about it in their discussion about how really you have to be, I believe they said that the timing of transplant has to be reconsidered in patients with FIC1, and it was a very kind of less than ambitious discussion about transplant for FIC1. But when you really look at their data, one of the patients that had fibrosis or developed portal hypertension didn't have a biopsy, and so their portal hypertension was not from fibrosis. Likely, it was probably from a portal vein complication that gave them portal hypertension. One of their patients had autoimmune hepatitis, and so it's hard to blame that on PFIC1. One of the patients had chronic rejection, and so those patients really that has nothing to do with PFIC1. And two of the patients with cirrhosis had fibrosis without steatosis, which number one calls into question in my mind whether these patients even had PFIC1. But they were counted as PFIC1 patients and patients that developed fibrosis and cirrhosis. But I'm not sure that those are patients that really developed it because of PFIC1. And so although they had, most of the patients did have steatosis, I think it's very, it's not really strong data suggests that the PFIC, that the cirrhosis that these patients had and the fibrosis these patients had anything to do with PFIC1. And so a larger study came out in 2018, and it's a great paper. And so if you're going to read one, I would read this one. They had 24 patients, which is good. They had 87% survival, which is very good data, good results. 4% of their population required retransplant. None of those had to do anything to do with PFIC. I believe one of them was a vessel thrombosis, and there was another that was a duct problem due to the donor, and another one was, I want to say one of them was chronic rejection. Most of the patients had diarrhea, and again, I think that this has been shown over and over again in different studies. About 80% of the patients have diarrhea. 90% of this population had fat in the liver when it was biopsied, and about 40% of the patients did experience pancreatitis post-transplant. So again, this is a multi-center look at transplant for PFIC with good numbers. We did a recent study. It's kind of in publication mode, where we looked at 6 patients who absolutely had PFIC. These are patients that were they're genetically diagnosed with PFIC1. All of the patients are alive. All of the grafts are their initial grafts. It's a 13.2 year follow-up, which is probably more like 14 years by now. We've been working on this one for a while. The patients all have normal bilirubin. They do, similar to biliary diversion, and we don't know all about these diseases, but oftentimes these patients have intermittent transaminitis, numbers that, normal of less than 50, their numbers go to 100 or 150, and then they come down. And I don't know if it's a similar pathophysiology to what happens after a biliary diversion. It'd be hard to imagine with a new liver, but and a lot of patients get biopsied for those changes. And so many of our patients who have had PFIC1 transplants have been biopsied for that. We have well-documented steatosis. The patients were all have some degree of steatosis. 2 of them had mild to minimal fibrosis that was present on their biopsy. None of the patients are cirrhotic. None of the patients have developed portal hypertension. Our oldest is currently 26 years after transplant. He was one of the original kindred. He has normal LFTs. He had a biopsy at the time of an ERCP, I believe, that at 23.7 years after transplant, and it was steatosis. He had mild fibrosis. He also is interestingly not on any immunosuppression, something that we do here in Pittsburgh, not infrequently. So he is completely off immunosuppression, and he has had, I want to say, 6 or 7 episodes of pancreatitis in the past decade or so. ERCP is endoscopic retrograde cholangiopancreatography, where you go in and one of the causes of pancreatitis can be an issue in the pancreatic duct, and ERCP is a way to kind of relieve that. And so he clearly has and has suffered from pancreatitis, but he's very well. And when you meet him, you really you don't know that he's had a transplant. He looks wonderful. So, and so in summary, contrary to what some studies show and what some people say, liver transplant for children with PFIC1 offers good short and long-term results. They have good patient and allograft survival, and it's similar to survival rates with other cholestatic liver disease. That's not to say that the children and adults don't have issues. It's a systemic disease. They do have extrahepatic manifestations of PFIC1, and those are manifested mostly as diarrhea, pancreatitis, and issues with weight gain. Patients do, no question, develop allograft steatosis, and I think that if you do a liver transplant on a patient and they don't develop allograft steatosis, it's perhaps a different disease. And so there is an absolutely unknown progression to fibrosis and cirrhosis in the patients. And the studies, because of small numbers and overall a very heterogeneous population, the studies are a bit complicated. But I think that it's important to understand that steatosis does happen. It's important to understand that it can progress to fibrosis, but the timing of that, the etiology of that, and how to prevent that are really unknown. And so what do you do? And I think this is a topic that everyone wanted to talk about, post-transplant diversion. And so if you remember yesterday's talk, I said that biliary diversion was discovered or kind of shown when a patient had a bowel obstruction. And so patient has PFIC1, they have a bowel obstruction, they put a tube to drain their stomach, they drain the bile out, and the itching stops. In 2009 in Japan, a patient was transplanted for PFIC1. It was a living donor, and they had a biliary complication, and they placed a percutaneous drain. During the time the patient was developing pruritus and did have some allograft steatosis, and lo and behold, when the biliary drain was open and all of the bile was being drained, the allograft steatosis resolved, diarrhea improved, and the pruritus that was there all but resolved. That patient actually was retransplanted and is one of the first cases that included an external biliary diversion at the time of transplant. And so those are the 2 studies there in case you wanted to look them up. And so in Brussels, just after making many sprouts and doing whatever people in Brussels do, they transplanted a patient with a living donor for PFIC1. The patient was not from Brussels. I forget where they were from. They returned home on cholestyramine and Actigol, and they did have early diarrhea post-transplant, but it wasn't severe. And about 2 years after returning, the patient developed severe diarrhea, protein-losing enteropathy, which means that they were losing protein into their stool, was dehydrated, and returned back to Brussels, and was biopsied and found to have severe allograft steatosis. And so they had elevation in liver numbers at the time of presentation, and they went on to do a liver biopsy. And so on the left-hand side, you can see that there's, I'm sorry, on the right-hand side of the screen, you can see that there's fibrosis in the middle biopsy. There's steatosis in the middle biopsy. In the middle picture, there's one with fibrosis, and then a biliary diversion is done, and that's on the right-hand side, and you can see that the biopsy has no steatosis and kind of about the same amount of fibrosis. It almost looks like exactly the same piece of tissue, which is impressive. The middle cartoon is a picture of a liver transplant. If you remember back to the transplant talk we did yesterday, there's a roux limb that we use, an intestine piece that we bring, and is normally attached to the native intestine here. And so it comes down like this. This actually, at the time of transplant for PFIC1, we can use the biliary diverted piece of intestine actually for this, and put it down to this intestine, or regardless, all of the bile for this patient after a liver transplant here would drain through this roux limb and go down to the intestine and be absorbed. These folks in 2012 took this roux limb, cut it here, and brought it out to the abdominal wall. And so there's a hepaticojejunostomy here. That's HJ. It drains the liver. G, I assume, is graft liver, and it drains all of the bile out of the liver. And so all of the bile is going out of the abdominal wall. And you can see the progression of biopsies here from left to right. I think that it's this is a classic case. It's kind of one of those first line cases that kind of starts people thinking about maybe we should do this. And so why not do this at the time of transplant? And indeed, a couple of groups actually, but one of the groups actually started to do this at the time of living donor transplant. And you can see here in the cartoon, here's the liver. These are the allograft bile ducts. It's hooked up to this roux limb, and instead of the roux limb going to the intestine and draining out and getting reabsorbed, in this case, they attach it to the colon. And so all of the bile and all of the bile salts, instead of draining and being reabsorbed and recirculated, it drains into the colon. This patient had 2 biopsies, interestingly, one of them in 138 days, and then another one 9 months later. This is one patient, so huge experience, but it's one patient. And their biopsies had some steatosis, but it was less than 20%. 30% is really kind of the line where you start to say this is more severe steatosis. But this liver had some steatosis. This is a living donor from dad, and dad was a carrier of PFIC1. I can tell you just a little bit of follow-up. This has been done a few times with the roux limb anastomose to the colon. We've done it, but another group did it in Connecticut, and it was the Yale group. They actually did this, and in one patient, it went well. In another patient, they developed allograft liver abscesses, presumed from cholangitis, from bacteria going from the colon up into the liver. And so I think that this can be done. I don't know if it really is the time to do it at the time of transplant. I think that experience will increase over time, and I think that it is a consideration. But my take on this would be, if you know that allograft steatosis occurs in 80 to 90% of the patients, or even more, but only leads to severe disease in a limited number, and you know that most of the patients, 80 to 90%, will experience diarrhea, but it does not lead to severe complications, the majority of those patients, it would probably be, my recommendation would be to either do an external biliary diversion at the time of transplant, or to consider just not doing a biliary diversion and following the patient. And we've done, I think that those are really the considerations. And it's just a matter, I think, of how well the family and how well the patient understands the risk, and understands kind of the process. And if you said, look, there's a pretty good chance that you won't ever need a biliary diversion after liver transplant, but we could do one at the transplant in case it were to develop. It's really, I don't think there's enough data to really say you would do it either way as a primary. And so to me, it would be reserved for complications of PFIC1 until there's a little bit more data. And then the next question, and kind of to follow that, is if I told you that there was a medical treatment for this that could avoid diversion at the time of transplant, which it may be, if ileal diversion, or if a pre-transplant diversion or partial external biliary diversion is equivalent to IBATs, IBAT inhibitors, then maybe we should talk about putting patients after transplant on IBAT inhibitors and seeing what happens to their steatosis, since it's a medication and not a surgery. And so I think that is that is something that is yet to really ever been tried, at least to my knowledge. All right, switching gears now to PFIC2. So in many ways, transplant for BSEP is essentially you're just transplanting a protein. Unfortunately, it requires an entire liver around it for it to work. The new protein that is included with that liver is exposed to the blood, and so it's on the canalicular membrane. It's the product of the gene, and it is new. It's new to the patient. It's not been seen before by patients that have BSEP deficiency. It's normal to have. It functions, and that's why you do a transplant. However, the actual protein has not ever been expressed in that patient before. In response to that, just like anything else, you can develop an antibody response to BSEP, and it's just another antigen or just another piece of protein that you can develop an antibody to. And so when was this described? How did it really kind of how was it really noticed? It was a syndrome back in 2009, and so it was really described in a single patient. And what the patient saw was that they started to develop pruritus and cholestasis, so they started to become jaundiced after a liver transplant for PFIC2. Interestingly, after liver transplant, if you're going to be cholestatic and jaundiced, one would expect your GTP, which is a marker of bile duct damage, to be very elevated. And so indeed, we follow GTP after liver transplant as a sign for bile duct stenosis or injury. This patient developed cholestasis with high levels of bilirubin in the blood, pruritus, and their GTP was normal, which was exactly as one would expect in a patient who had primary PFIC2. And so it actually they did a fairly extensive workup, and when you read this description, they did a real long transplant workup before they checked the bile salts. And I think when they found that the bile salts were as elevated as they were, they suspected that maybe this is a recurrent disease. And so in the initial thought is maybe this is an issue with the donor, but indeed they eventually went on to find that there is antibody both on biopsy and in the blood. And so here is kind of what they did as a general workup. You can see on the right hand side, they did a liver transplant. They had a clinical symptom, and you can see in the kind of pictures below that the actual deposition of antibody, and they actually typed that antibody to show that it was anti-BSEP antibody. And autoantibody in this and autoimmune, and it's not really autoimmune, it's allo-immune. The protein is not own patients. It's so, when you develop an autoimmune disease, you develop a disease against, say, your own islet cells, so you develop diabetes. These are allo-immune, and it is a little bit, there is some differentiation there, in that allo-immune processes can sometimes be easier to treat than autoimmune. And that's not saying that this is in any way easy to treat, but I think that it's, there is some degree of the ability to treat this and to exhaust the immune system against an allo-immune process much more than it would be if it was an autoimmune process. This is the group that published the initial, it really didn't project well, I'm so sorry, published results from 11 other patients that all had this PFIC-2 recurrence. This is it was a multi-center look at these patients. They were all found to have no BSEP antibody expression pre-transplant. They actually had serum that they checked for the antibody, and they found it post in most of them, and they were able to actually analyze post. Most of these patients had symptomatic recurrence of the 12. It was really the time between the transplant and the development of symptoms ranged quite a bit. But it was in the area of I think the earliest was a few months after transplant, and the latest was 12 years after transplant. And so there's a big variation as to when this can happen. And so it's a clinical syndrome. When you look at the overall numbers, it's about 8% of the transplanted patients for BSEP disease. Again, it's a small population of patients. It's really hard to tell, if that 8% is accurate. But in patients that it starts, or at least in the history of this, it tended to recur after retransplant, and it makes sense when you consider that the antibody that is generated against normal BSEP protein, and so unfortunately that BSEP protein is going to be very similar in every patient that has a normal BSEP. The only patient that wouldn't have a normal one would be somebody that had PFIC2, and so these do recur after retransplant. There have been patients transplanted 3 and 4 times for this, but it's important to realize that there are things that can be done, and so there is an accumulation of data over time about these diseases and about this issue, and so one of the good things is that this allo-immune kind of recognition is similar to that as seen in solid organ transplant, and ABMR is antibody-mediated rejection. It's seen in rarely in solid organs, but it's certainly seen in heart transplant. It's certainly seen in kidney transplant, but it's well studied, and there are drugs kind of in development for this type of recurrence. Of course, everything that you do to immunosuppress somebody has its own side effects, and can lead to all sorts of complications. But I think that because of the data that is accumulated over time with antibody-mediated rejection, the treatment paradigms and kind of the treatment protocols are starting to be developed for this, and are not as foreign to transplant surgeons and liver transplant surgeons as they were, say, 15 or 10 years ago. And so there's a slew of anti-metabolite drugs that can be utilized to decrease antibody production. Once antibodies are made, one of the ways you can downregulate the cells that make them is with plasmapheresis, and so you drain all of the plasma out of a person, and at the same time you replace it with frozen plasma, and so you essentially draw out all of the antibody and many other things along with the antibody that is there, and replace it with serum that does not have it. That over time can what you would say is exhaust the cells that make these antibodies, and can lead to treatment, and can lead to kind of a remission in this issue. Bortezomib is a drug that has been used quite frequently in intestinal transplant and renal transplant. Bortezomib is a proteasome inhibitor. It's a drug that actually the cells that make antibody are called plasma cells. Bortezomib is used, or was initially used in a type of cancer called multiple myeloma, which is a cancer of the plasma cells. And bortezomib works to inhibit the production of antibody from those cells. And so that when you inhibit antibody from a plasma cell, you actually downregulate the plasma cell, and it gets rid of the kind of clone of plasma cells that make that antibody. Bortezomib has been used extensively, has not been used to my knowledge in patients that have BSEP recurrence, but it's certainly something that should be. And then bone marrow transplant seems severe. It seems like something that would be a major undertaking. However, if you have a patient who had a liver transplant who needs another liver transplant, who could very well need another liver transplant, bone marrow transplantation at the time may actually lead to a kind of a more long-term cure, especially if there's living donor options where you could do a well-matched bone marrow and do a well-matched liver from that same person. It would actually be a way to ameliorate all of the production of antibody against the new liver. And that's really the only way to completely do it. This has never been done, it's never been tried, but it's certainly something we've talked about in the past clinically, and I'm sure has been talked about in other centers. And so patients with PFIC2 often require a transplant earlier than those with FIC1. The extrahepatic complications, thankfully, of FIC1 are not present in these, but unfortunately the disease can recur, and patients really must be monitored quite closely for that recurrence of disease. One of probably the easiest way to do that is to monitor bile salts. As the GTP is not going to elevate, you can monitor bile salt levels in patients. And obviously when you get routine liver function tests, you check the bilirubin, but the bilirubin may be a later finding than, say, the bile salts. My only caution to that is that you need to find out what the normal or the patient's bile salt level is early after transplant, because sometimes patients with PFIC2 can have elevated bile salts, mildly elevated bile salts after transplant, even those that are doing well, that don't have any recurrence, even in the first few weeks after transplant. And so that is again it. I'd be happy to take questions from the audience about this. And again, I'm so sorry I was late.
No apologies needed. Thank you so much for that. I think that is definitely something that in general we don't have a lot of education about. And I'm aware of these complications, but I've learned a lot from that presentation. So I really appreciate you taking the time to put that together. I know that that's very specific and, as you said yesterday, very dense, but that's super important, and I'm really glad that we have that now.
Well, it's nice actually to have the kind of the audience that understands the issues, and I think that when you're talking to an organization that really has patients and families and care providers, I think it's it makes it a little bit easier to do this.
Absolutely. Well, thank you. Oh, go ahead.
Kyle, this is Jim. Sorry to jump back in. And if you got to jump back into the OR, I don't want to keep you. But
no, I'm good.
Yeah, there was a couple questions that were proposed to me. I think that I think would be good to get your opinion on. I think one that pops out specifically was there was a patient on the webinar who has 2 kids with TJP2. One's post-transplant, one's diverted, and is reaching that wonderful age of 18, where we have to decide: do we list them early to get the pediatric, get them listed with the pediatric PELD or under pediatric guidance, versus wait? And so, what would your thoughts be in TJP2 for that?
I don't think there's any harm in evaluating and listing somebody, and so. Just like, to list does not necessarily mean you transplant. And so I think it's not a bad idea to get the priority. The question would come: how far along are they in disease? How long would it be before realistically they would absolutely need a transplant? But I think with that disease, I would say it's probably not, not a bad idea to consider at least the evaluation.
So I'm gonna push it a little bit, right? Because I kind of said the opposite. I thought that if you're not imminently headed to transplant, but I kind of gave a time frame of 3 to 5 years, and I thought that if the team didn't think you needed a transplant in 3 to 5 years, probably you wouldn't need to be listed. But Would you think that?
No, I think that's yeah. I'm just going by disease, and I think 3 to 5 years is perfect. I mean, I completely agree.
Interesting. Thanks for bringing that up.
Yeah, it is. I mean, there is a you know, the way that UNOS allocates organs is very different adults and kids do get you know, some degree of priority. And so I will stay off my soapbox about UNOS and their ability to allocate organs and the need for transplants for children. But I think one of the things that they do right is that they do have some degree of priority. And I think that, you know, 17 years old will need a transplant in a year or two, depending on disease severity. I would absolutely consider listing.
Okay, thanks for that perspective. It sounds like we need to have a soapbox conversation about UNOS and the scoring system in another time. But okay, so I have a few follow-up questions, a few live questions and a few specific to your presentation.
Sure.
Is it okay if we stay over just a little bit?
Yeah, that's fine with me.
Okay, and then for anybody in the audience, if you have to go, this is recorded and we'll make it available later on. So we'll make sure that you are able to hear the Q&A. I have a few, 2 questions specifically about each complication. So for PFIC-1, with the diversion, you mentioned that it is done with living donation. Can it only be done with living donation?
No, it can be done with either.
Okay.
Yep.
So there's not a benefit of one over the other?
No. Nope.
Great. Okay, and then with PFIC-2, you said that we're learning quite a bit more about the AIBD complication.
Yeah.
Are we learning enough where we can identify based on like genetic testing results which patients are more at risk or likely to develop this complication post-transplant?
No, I mean, I think that it is a classic antibody-mediated type of process, and yeah, so short of there's no, as far as I know, there's no data to show that you know, a specific type of mutation would cause more likely to have development of the antibody. Although, you know, when you think about it, making no antibody or making no protein, so you know, someone that doesn't make any protein may be more likely to develop an antibody against it if you if you put a new protein in. But again, a total conjecture, and the numbers are so small.
Okay, great, thank you. Okay, I have a general question pre-transplant about ascites and splenomegaly specifically.
Yeah.
So I'll ask them both at the same time. Feel free to whoever answer. So for ascites, there's been a difference of opinion, and this is pre-transplant. They've been told that, you know, one says it'll never go away, another says that it can go away. The ascites in this particular instance has gone away and they've weaned off their diuretic or their water pill. And let's see. So, you know, they were told that if the ascites comes back, then they would be put back on that pill. So what is your stance with ascites pre-transplant, and if it's something that just kind of ebbs and flows, or is it something that kind of needs to be addressed aggressively? We'll start with that one first.
Jim?
I'll take that one, yeah. No, it's fine. That's obviously a medical question. So, I mean, the short answer is yes. I mean, ascites can absolutely ebb and flow. And that sometimes you can have ascites, and if you treat it appropriately with diuretics, salt restriction, and other measures, it can absolutely go away. If ascites has resolved, then usually that's on imaging. You know, a lot of times the ascites that we picked up is on an ultrasound or additional imaging. You know, if you're feeling it on exam, there's generally a moderate to large amount there. But if it goes away and you know, you don't need a diuretic pill anymore, then I think it's fine to come off. Does that mean it won't come back? Absolutely not. You know, again, I would suspect that it likely, you know, could or would come back. You know, new onset ascites is something that, you know, we often talk about concern for other, you know, kind of pathology inside the belly, right? So oftentimes you can have new onset ascites that, in females, sometimes you worry about things like ovarian cysts and the like. Obviously, if someone has liver disease, you have to think about their liver disease. I think the other thing that you sometimes worry about is, sometimes you can get a little fluid in the belly, and if that fluid gets infected, you can get what we call peritonitis or infection of that fluid. And so sometimes you need to sample it to make sure that antibiotics aren't needed. But, ascites is one of those things that definitely may ebb and flow. Often, though, it does kind of portend a progressive nature of the disease and needs to be monitored for moving forward. And if you had ascites in the past and then developed something like belly pain and fevers and symptoms like that, I think reassessment would be one of those things to make sure that that fluid hasn't reaccumulated and potentially gotten infected going forward.
Okay, and this was in specific to an instance. So I think she's just wondering and trying to get some reassurance. The ascites went away, and so she went off her diuretic. It wasn't based on imaging, it's just on exam, but just making sure that that was appropriate to come off that diuretic, if that's something that normally happens, or if they should have stayed on to prevent that ascites.
I mean, I guess I defer to the care team there a little bit. If the ascites is absolutely absent and the care team decides to trial off to see if we can be without one less medicine, I think that's perfectly fine. That doesn't mean necessarily that it wouldn't come back, and I think it just needs to be monitored for moving forward.
Okay, and then in the same regard, with enlarged spleen or splenomegaly, is there a chance that the spleen could go down without transplant? Or is that something that's just like a progression sign and it won't go away unless further intervention is done?
Spleen's at least an organ, so I'll do that one. It's yeah, no, I think that the chance of you developing a type of shunt or a spontaneous shunt that would decompress your spleen enough to decrease the size, it likely would not. It would be very surprising for that to happen. So.
Okay. And then specifically, another question was raised about PFIC-3 post-transplant. Will the spleen size go back to normal? This is about a month post-transplant.
Yeah, so it depends on the age of the child and how long they've been, how long they've had portal hypertension. But in general, little kids grow into their spleen, and so the spleen won't really particularly shrink. It just won't grow, and it'll kind of go up underneath the rib cage over time. If it's a like a teenager that was transplanted and they had a portal hypertension for a long time and their spleen is very big, I'd be a little less optimistic about the spleen completely disappearing.
Okay, let me be more specific. So in one instance, the first instance, it's a teenager with a spleen size of 18 centimeters. Second instance, the post-transplant child is 6 years old. Yeah.
So number one, the teenager, I would say that the spleen will always be big. The matter of whether you can feel it or not, or it causes any sort of issue is kind of really the other question. And then the small child, the 5-year-old, its spleen should essentially they'll grow into it.
Okay. Okay, yeah, that's very helpful. And Jim, we don't have to go back into it, but I think this is kind of what I was referring to earlier with that question about like PFIC versus cirrhosis, and like which one is PFIC, which one's cirrhosis, which one's progression of disease. I think these are questions that I was trying to couple into that, if that makes any sense, because it's really hard to draw those lines as parents or as patients, really.
Yeah, for sure. And again, I mean, I think probably at the end of the day, most of the complications seen in PFIC is due to the end-stage liver disease and not necessarily the underlying gene defect. Again, I think there's probably a few exceptions to that rule, but particularly pre-transplant, the complications that develop are that of its namesake, so progressive liver disease.
And again, I don't want to get too far down this road, but the progressive portion, when things progress to this nature towards end-stage liver disease, there are certain things that are irreversible. And so are these some of those instances where those are irreversible?
The definition of irreversible is changing, and so I think, again, a lot of this, we have to be a little bit careful about, right? I think that, and even, the sense that, it's generally not a straight line from beginning to end. And there are, as you mentioned, ebbs and flows where you may have a period where there's ascites, then it gets better, then it comes back, then it gets better, periods of itching, periods of cholestasis, periods where there are acute worsening and then maybe some improvement. For those with the more severe phenotypes, it generally tends to be, a progressive trend line towards irreversible end-stage liver disease. But I think that, as we've talked about multiple times in these webinars, there is a lot that we still need to learn about particular genetic defects that may portend better or worse outcomes in certain situations. We use this term PFIC to try to clump these patients together so that we can, learn more by numbers and advocate more by numbers and, gain more data by numbers. But probably grouping them in this way, can be a little bit problematic when we try to then apply blanket solutions to all that is PFIC, because I think it's a very patient-specific process that needs to be taken into consideration.
Right, but I do think it leads to good talking points with a physician or with your, with your child or with your doctor, with your child's doctor. Okay, so back to transplant. So have either of you had experience with small bowel bacterial overgrowth and PFIC-1, both pre and post-transplant?
I don't think I have not. I mean, I think that, when you do surgery on patients and their intestines, you can sometimes slow the transit of kind of food through the intestine. And I can see that you would be at risk. Kids with PFIC also tend to have issues with diarrhea, so it would make it a little less likely. But it's not something that I've ever seen.
I've only seen what Kyle sees.
Okay.
Yeah, it's not something that would, with PFIC-1, it's not something that would really, because their gut transit is pretty fast and they tend to have a fair amount of diarrhea. It would surprise me. You could theoretically have some bacteria in the diversion itself, but again, it's a short piece of intestine with a lot of movement, and so I would be surprised.
And I personally, again, I don't want to get too much here. I always question how bacterial overgrowth, how that diagnosis is made. Our guts have billions and billions of bacteria in them, and that is normal. And so I think, not to say that there isn't situations where you can have, certain colonies of bacteria dominate that cause problems, but I think oftentimes bacterial overgrowth, to me, is a diagnosis where generally it's suspected there's a treatment and the patient gets better with the treatment, and that's the confirmatory test, and I'm not so sure that's the best way to approach it.
Okay, thank you. That's helpful. So unless we have any more transplant specific or any other specific questions, okay, one more came in. What do you consider, or what is considered end-stage liver disease?
Well, I think for,
No, go for it, Kyle.
Yeah, no, I mean, I think for different indications, it means different things. And so to me, development of complications related to liver disease is the sign of end stage, and whether that's, portal hypertension, ascites, or in other kids, growth failure, I think that those are all kind of the biggest signs of kind of end stage liver disease. Kids, you can't really use bilirubin, and clotting factors in kids with PFIC-1 are oftentimes off because of fat malabsorption, and size to a certain degree is off. And so I think that it would be, development of portal hypertension, ascites, and the complications thereof. And obviously in kids that with both of those, development of masses in the liver would also be another sign where I would say it's nearing end stage.
What about esophageal varices?
Yeah.
Both just
That
there.
would be a sign of portal hypertension, and kind of that would be a sign that there's significant scarring in the liver.
Okay, even if they are not actively bleeding.
Yeah, I mean, I think if you have varices, that's kind of the one of the first signs that I would say, hey, we need to start thinking about, transplant. Not so much that you need to do it immediately, but it is kind of one of the first signs that indeed your liver disease is severe enough that you have portal hypertension. Doesn't necessarily mean that you need a transplant right away or even in the next 5 years, but I think that's where you start to say, okay, well, if I'm not at a transplant center, I need to start to at least be seen by somebody.
Okay.
I don't know, Jim, if you had something else.
No, I mean, again, this is one of those things where I think it's just a constant discussion with your care team, right? I mean, end-stage liver disease in itself is irreversible liver disease. How you pinpoint when it's irreversible is challenging. I agree with Kyle that I think it's much better to think about a child in advance who's headed towards transplant and be prepared for that than suddenly try to rush it at the end when they're acutely bleeding in the ICU because they've had a GI bleed, and the transplant team has never heard about this child or their disease before. So as Kyle's kind of mentioned, no harm has ever come from discussions or meeting with the team, and so I think the earlier that you kind of have those discussions with your physician team, I think that the more beneficial it can be.
Okay. Okay, one more question came in. So how bad does itch or quality of life have to be considered for a transplant without signs of end-stage liver disease?
Yeah, I'll take this. And again, it's going to be different at different places. I trained at an institution where there were people who absolutely did not believe that you should transplant a child for an itch, no matter how bad or how severe. I tend to think that it should absolutely be a consideration depending on the quality of life of the child. I mean, I've seen kids who just rip themselves apart trying to relieve their itch, and the parents are washing sheets 2-3 times a day because it's bloodstained everywhere, and that to me is really not. There are certain diseases where the itch might get better. I think Alagille's is one where maybe early on there's some intense itch, but if you can kind of get over some hump down the road, maybe things get better. I don't think that's the experience in PFIC, and so I think if and particularly it's looking at how well outcomes have been established in transplant, right? If we were talking about a kid in 1968 who was itching for transplant, I might think twice about it, knowing that transplant back then the outcomes weren't nearly as good as they are now. But I think that if a child is severely itching to the point of destruction, and it's a distressful thing for the family, and they have a disease that we generally think is going to progress that I can cure with a transplant, I think it's absolutely appropriate to consider it.
It's a great answer. Okay, I don't have any more live questions. I think we've answered everything that's come in live. Naturally, I have a list, like a 2-page long document of questions that I could answer, ask you both, but we can leave that for another conversation. I just really want to thank you both one last time for dedicating your time to do this. I know it's been really meaningful and impactful to everybody who's been able to be on the call. And we'll be able to post these on our website for people who may have future questions. And I think you both did a beautiful job kind of making this really difficult disease kind of feel like we understand a little bit more from the scientific perspective. So I really, really appreciate you taking so much time to speak with us.
Well, for me, it's a pleasure. So anytime.
Thanks.
Absolutely. Emily, it's good seeing you virtually. Hope to see you again in person soon.
We'll have to do this in person sometime.
Yeah, absolutely. I'm going to hold you both to that. All right. Thanks, guys. And thanks, everybody, for attending. If there's any follow-up questions, just let me know, and I can shoot these guys an email, and we can keep the conversation going if needed. Thanks, everybody.
Great. Thank you.
Thank you. Bye-bye.